game-changing discussions on the big ideas that shape our thinking. This is One2one.
Dupe Elebute-Odunsi is co-founder and CEO of the Marcelle Ruth Cancer Centre and founder of the Women in Healthcare Network. She's a consultant hemato-oncologist, trained and worked extensively in some of the UK's most prestigious centres of excellence, including St George's Hospital, King's College London, and the Royal Marsden. She's also my guest on the show today. Dr. Elebute-Odunsi, welcome to One2one.
Thank you very much for having me.
A real pleasure. A real pleasure. So, Dr. Dupe Elebute-Odunsi, you are a consultant hemato-oncologist. You are co-founder of Marcelle Ruth Cancer Centre and also founder of the Women in Healthcare Network. You are widely celebrated for building the first comprehensive cancer centre in Nigeria. Dr. Odunsi, you graduated in 1986 from the College of Medicine, University of Lagos. You underwent postgraduate education, medical education in internal hemato-oncology with various centres in London, including St George's, the Royal Marsden, no less, St Bartholomew's Hospital. I was there very briefly myself. I met the great Professor J.S.P. Lumley.
Oh my God, yes.
Who I remember saying to me at one time, we all learn by embarrassment. He said to me,
True, very true. I must use that actually. Trainees, yes.
I've never forgotten it.
Yeah.
You obtained a prestigious fellowship from the Leukemia Research Fund and obtained a Doctor in Medicine degree for your efforts at the University of London and for your outstanding performance. So after 30 years of service and practice in the UK, you made the bold decision, after having served the NHS for so long, to embark upon this journey to Nigeria. So what precisely would you say inspired this extremely bold move, really? And perhaps you could come on to it later. Well, what exactly does it mean for it to be said of you that you've built the first comprehensive cancer specialist centre in Nigeria?
From my perspective, I know people always ask me that question. I think they asked both my husband and I the question because I co-founded Marcelle Ruth with my husband, Bolaji Odunsi, who is in the finance industry. So I think for me, it was the realization around, I think, my 50th birthday that having gone to medical school here and been involved with the medical services here because my parents obviously worked both in the public sector. My father was provost of the College of Medicine. They taught in the medical school, postgraduate students, and then they started the Lagoon hospitals because they had this vision that actually the private sector was what was going to help to drive excellent standards of care in the Nigeria health sector. So I think I was sort of piggybacking on that and seeing things as I came and went. And then later on, it became something that was quite important for me. But it was more about coming to retire in Nigeria. That was the plan. That was the plan. But plans made and other roads followed to come and spend the last few years of my working career and to try and, I think, give back. And I don't think we say it in a sort of funny sort of way. It's just about coming to contribute to what is going on here. And of course, for those of us who lived abroad for so long, you also have this sort of feeling that you have maybe not given your children an opportunity to grow up here and to know Nigeria and to really understand where they're from. Whereas we have this positive experience of having gone to school here and then and lived abroad. So it was really about that. To be honest, if anybody, fast forwarding now to the hospital will be 5 years in December. But of course, building the hospital took 2 years, and then because it was around COVID, so it took a bit longer than we thought. So we've been in that transition now for about 8 years, but actually the hospital will be 5 years. But never in my wildest dreams, so I'm not going to lie, has this story panned out the way I thought it was going to be. When I first started looking at a venue for a clinic, because what it was going to be, I was looking for a 2-bedroom flat in Oniru, you know.
You're a long way from that now.
Yeah, a long way away from that. I mean, that's where getting my husband involved, the story changed the whole dynamics. But I think also, and I always refer to it, I think that when you embark on a journey that I think it truly is um, designed by God, or whatever higher being you believe in, then you realize that actually what you think you're doing and where you might get to might be two totally different stories.
Out of your hands.
And one of the deciding or changing things for me in particular, I was going to a dinner party at a girlfriend's in London. And my husband wasn't around and his wife wasn't there. We sat together at this dinner table and he was asking what I did, and I said I was a doctor. And, people always sort of sit up and then you say you're a consultant, in a teaching hospital. And so this conversation continued because usually people either stop and ask you a medical question, a personal thing. They want you to, I have a cough. What do I do? That kind of thing. But he seemed quite interested. And I was going on about wanting to come back to Nigeria and get involved with the health sector. And he didn't say too much. He listened to me, and as I was leaving, he gave me his card and he said, come and see me sometime. And I looked at it, and he was a gentleman called Chris Starlin, who was the head of life sciences for KPMG worldwide. And so we did go and see him, and he was the one who said, something, actually, there's a massive gap in your country. You're a trained hematologist, oncologist, and in particular, there is a dearth of infrastructure, particularly with radiotherapy machines and so on. I really think you should consider doing something more impactful rather than just something to retire into. And that's how the story, so the combination of him with Bolaji, who now did a lot of research, and from a business point of view, felt that it was something that would be quite useful to consider doing.
Sure.
And that's how the story sort of started.
Yes.
Now, when you ask me about what's it been like being back, so first of all, I think if we spoke to about 100 people and said we were coming to do this and actually moving back and you were actually going to build, I know you're laughing already, right? Everybody's going, are you sure about this? You're not just coming to live in Nigeria, you're bringing your money to come and invest in Nigeria. But, again, I think we just came with a totally different mindset.
Absolutely.
We hadn't lived here for years. So I think all the negativity, yes, we heard it, but somehow it bounced off us. We just got on with it, right? And even though it wasn't an easy journey, and there are a number of stories to be told, particularly in construction, and the difficulties thereof, and bringing the radiotherapy machine to the country and so on. But it happened. It kept going. There was never a situation where it was a complete stop. Yes, it was difficult, but I mean, when you've worked in the NHS like you did, when you've done postgraduate training, none of it has ever been easy, right? This is a different type of difficult.
Absolutely.
And we just sort of got on with it.
Yes.
But I do remember the first week after we opened, and a number of patients came in and they said, I'm not sure I'm going to come back here because you have this cancer in the name of your hospital. I'm not sure I want to, come back. And I called Bolaji and I said, maybe we should change the name of the hospital because there's this stigma about cancer. And he looked at me and he said, well, okay, you brought a radiotherapy machine into the country, one of only 10 when there should be like 1,000. And you want to say this is not a cancer hospital, you're on your own. Hey, but yeah, looking back now, we're almost 5 years and we've seen almost 5,000 patients at Marcelle Ruth. And in particular, I think what really strikes me is that we've seen about 200 children with cancers at Marcelle Ruth. And it's just been, you realize that when people say there's a need, they really was a need. There is a
There
need.
is.
There still remains a need. But the need had to be done, I think, in the way that we've done it, to provide all the aspects of care for patients on the one site, which is what you're referring to as this comprehensive one-stop shop. And that is what every single day when I see a new patient arrives, particularly when they come from other parts of the country or indeed from Lagos, and the patient's coming back like with your practice from abroad, and they describe, so this gentleman I saw a few days ago had been to a teaching hospital, then he went to a private hospital, then he went to Turkey, then he came back, then he did this, and and you're dizzy. Just think about a patient who's been told they have cancer, and then this is the process they have to go through. I mean, nobody's holding them together. They're falling to pieces. And he was actually in tears during this consultation. So being able to provide everything that they need, from the screening to the investigations, to the imaging, to the theaters if they need surgery, to the inpatient beds, to the chemotherapy, and the radiotherapy, all in one place, I think is really been really an honor, to be honest, to be able to deliver this care.
Yes. And an honor indeed.
Yes.
So you've touched on several things in the course of this conversation already. And we are going to come back and talk about the need and the gap and that linear accelerator. We will come back and talk about all of that. But can I ask you first at this point, so what exactly inspired the name Marcelle Ruth?
Oh, okay. So, I mean, the answer is easy, but the journey wasn't. So for about 2 years, I was trying to curate a name and doing a lot of research, and my father, now of blessed memory, I remember, was very involved because he reads a lot, and we were Latin names and Greek names and the Greek god of health and all sorts of things and everything, but Yoruba names, and none of it really sort of gelled. And then when I was doing my research, I realized that quite a lot of cancer hospitals, even the Mayo, named either after people who had cancer, their cancer journey, or a family member, but the family are now sort of sponsoring the whole hospital. And so I was thinking to myself, well, who do I know who? And my mother-in-law, Marcelle Ruth Odunsi, had actually had a cancer journey from which she actually passed away. And then, of course, from my personal point of view, in gratitude to my husband, who actually has been my main investor to date, I thought it was actually the perfect name in her memory, and also to say thank you to him. But I think it's also important because although she was English and obviously her father was Nigerian, but she actually came to Nigeria in her 20s and lived here for all her life. She was a teacher. And she was a history teacher. I think she taught in Queen's School, Ibadan, first of all. Yes.
My wife went there.
Oh, there you go. There you go. And then she taught history at Igobi College. And
My brother went there.
There you go. And she became the vice principal of Igobi College. And it's quite interesting because lots of patients who come to the hospital suddenly say, oh my gosh, is this the same Mrs. Odunsi who was our vice principal? And then when the government started the government girls' colleges years ago, she was the first principal of government college, Agege, who celebrated 50 years recently and did something in her honor. And I always like to say that because people, when you say she was English, people think she was so Nigerian, because she spent most of her life here, and the memory of her students and so on, of her. And I feel from my point of view, it's great that we could be able to honor her name in this way.
Yeah.
Yeah.
I mean, a perfect tribute,
Yeah.
really, to someone who has contributed so much.
Absolutely.
No, well done.
Yes.
Well done, you. So Marcelle Ruth,
Yes.
as we now know, the origin of the name of the centre,
Yes.
was open to handle the detection,
Yes.
hopefully early detection,
Absolutely.
and treatment of cancer alongside other specialist conditions.
Yeah.
Now, we've had on this program earlier Professor Kingsley Ekweme,
Oh, yes.
the esteemed geological and robotics surgeon, and we talked in that conversation
Yes.
about the fact that there's so much late presentation of disease. About
Absolutely.
80%, for example, of cancer patients come at an advanced or late stage. Can you talk to me a bit about the burden of cancer disease in this country and perhaps across Africa? I know you mentioned earlier that you've seen about 200 children,
Yes.
for example.
So
Please.
yes, I mean that the 200 children is a bit of a surprise to me. The almost 5,000 patients again in this period again is quite a lot really. But obviously we're all sort of like a tertiary referral center, so we're seeing patients from all over the country and patients coming back from abroad. But there definitely seems to be a change, I think, in the presentation of cancers in younger people. So we've got quite a lot of young patients in their like 30s, 20s, 30s, 30-year-olds with colorectal cancers, 30-year-olds with breast cancer. So we seem to be seeing a younger population of people with cancers. We seem to have an increasing number of patients with cancers, and we can talk about the reasons why we think that could be. And of course, in our environment, we cannot avoid talking about, and I know that you had Mr. Masha recently, but what we put in our mouths and whether our foods are grown in areas where there is no, the pesticides and so on, the environmental causes or that can predispose to cancers. Obviously, we don't smoke that much in our environment, but we are seeing an increasing number of lung cancers, particularly in women. So at Marcelle Ruth, we are collecting data every day, and I can tell you already that we've seen about 12 to 14 young women with lung cancer, which is quite unusual in a population where we don't smoke. So that brings to mind what is going on with the pollution. So, there's a lot of generator use. There's, cars are not regulated in terms of the emission of fumes and so on. So I think we in this part of the world can't avoid the discussion about environmental effects. However, we all know, and more so now because we do the tests, that there's genetic predisposition to cancers. And again, just information that we are seeing a higher proportion of our patients with positive family histories of cancer. But you touch on on a point that I'm very, very passionate about. And then this is about this late detection and late presentation of cancers, which is in today's medicine really sad because it's a waste that doesn't need to be. And therefore, every time that I'm asked to speak or that I have the opportunity, I do say that if you don't remember anything else from this program, please do remember that early detection does save lives. Cancer can be cured because, again, in our environment, people think, no, it's a death sentence. It is not. And we pick up early stage cancers, stage 1, 2, even early stage 3 cancers. We can treat these patients and cure them for life. So that's a message that needs to be emphasized. I will say, though, we're beginning to see the change already. So this is 3-4 years. Quite a significant number of our patients are presenting early. That is for sure. And so I'm hoping that happens next, and I've been very fortunate to be appointed to 2 national task forces, one on cervical cancer elimination and the other one to do with looking at cancer control for the country. I think that now it's time to use our voice in a national platform so that it's not just about the patients who can afford to have all this done in the private sector. We have to have screening programs for the wider population. This is where we need to be. And they said there's a lot of work going on now, and there's been a lot of support from the government as well to try and get this done. But we're really behind the curve, so we need to really get this started now. And because it does make the difference. In most countries now in the world, cervical cancer is eliminated through HPV vaccination and so on. So that's where we need to be.
Absolutely, and the fact that you've touched on screening
Yes.
programs, it immediately it elevates the problem to a national
Yes.
level. So, but we're not talking really about wellness when we talk about screening.
Yes.
It's something the government has to get involved
Absolutely.
with.
And it's, to be honest, it's everybody's right to be informed, because that's one of the issues. It's people are not aware. They don't, and I don't mean even educated people are not aware, right? I had the opportunity a few weeks ago to give a talk at quite a big church. I mean, I didn't know they were that big, to be honest, when I was invited to speak, because a number of my patients had come from Abuja to us. And I remember giving this talk, and afterwards, they're very, very highly educated people, but the questions they were asking, and also the view of cancer. And I said, you do realize that most people that get cancer haven't done anything wrong. In fact, it's as much a shock to them. I said, so why would you have a work colleague who has cancer, who's unwell, who's going through treatment, and it's not the right thing for you to find out how they're doing? Or make sure that they go for their appointments? Because sometimes these people can't even tell people at work that they've got cancer.
Sure.
Because they don't want to talk about it, because there's a stigma, which delays their treatment, which reduces the risk of a chance of getting better. And you just see the light bulb.
Yeah.
And people suddenly realize that actually we're not helping, our fellow colleagues or family members when we could be. So those are the messages I think we need to drive.
Absolutely.
Removing this stigma. And also pushing the early detection story. And not just early detection, because of course there's detection, but talking about, it's so sad, the people that cannot then access treatment.
Yeah.
And of course that's a bigger topic.
Absolutely.
In our world right now.
And we are going to,
in our sector.
we're going to come to that.
Yeah.
So obviously we need to become a better educated society.
Absolutely.
You have just described what is a societal and in fact a socioeconomic problem, the burden of disease that exists.
Yeah.
But permit me to read out something you said. You've said, my big hope is for everyone to have access to healthcare. For people to walk into a hospital and trust and know that they will get the right diagnosis and treatment with compassion. So obviously,
I said that.
you have said many things.
It does ring out of something I would say.
And I'm quoting directly.
True.
Absolutely, quoting directly from the pumpkin.
Yeah.
Absolutely. So obviously you're speaking to the issue, the problem of access.
Yes.
But of course, directly linked with the question of access is affordability. Now, affordability, of course, is a big part of that access. It's fair to say, would you bet that you own and operate a first-class medical facility.
Thank you.
In what must be described, I think, as very much a still developing economy.
Yeah.
That's what Nigeria is.
Absolutely.
Are you confident that your services at Marcelle Ruth are, given the size and the scale of problem we described,
Yeah.
are you confident, are you reasonably confident that these services are affordable, accessible, really to the average Nigerian? And if not, how do you propose that we collectively as a society aim to bridge that gap?
Yeah. And it's a very important question. And I think that, for most of us who are sitting in the private sector, healthcare sector in Nigeria, must every day have this sort of niggling that although we know we're doing well by actually even being here and providing this care, which wasn't easily available. The majority of the patients would have to leave the country to go abroad, in particular to India, South Africa, that are far away. And there's the additional costs of their flights, their accommodation, before you even talk about the foreign exchange that they need to pay for their care. Now, there are two things to say. One is that actually it's the majority of the patients that come to a place like Marcelle Ruth are not patients who can afford this care out of their pocket. Okay, so a lot of them are actually being supported or sponsored, either by companies, their employers, some by government of bodies, some by NGOs. A lot of family members, and I mean, in our world, of course, if people run a GoFundMe campaign to say they have cancer, they're more likely to get people to help them. So that is, access, but they can still come to the hospital and they can still get there.
Sure.
And I am glad, I don't make no apologies, that we're able to provide that care. But in particular, because we're able to give it to them in one place and look after them properly, which is the other thing about access to care. But I always say that I don't feel that I came back just to look after the 1% of the 1%, although the majority of our patients are not that 1%, they're just that they're funded by that system. And so looking at it from a wider social point of view, it would be my dream, and just what you read out, that everybody should be able to access care. But I think that is the government's job. And that's where, so for example, I'm sure that even if these services could be provided in the public hospitals, you and I would give up a few days a week to go and help those places deliver the care. You and I would go and help to ensure that the medical students and the postgraduate students are taught.
Absolutely.
Because I know you've done a lot in medical education, right? We would do that for nothing, right?
Absolutely.
But we can't go and make every public hospital what it's supposed to be. And whatever expertise you bring to the table in healthcare, you also need the infrastructure. You can't do it without the two. We in the same way that I think there've been a number of infrastructure bills across Nigeria, particularly in healthcare, that are empty tomorrow because they've not been staffed, right? Or be staffed by the right level of technical abilities. And that is where, from a government point of view, it's that they need the talk needs to stop, and we really need action needs to happen on both sides. So infrastructure, yes, but training and making sure that the expertise is there to look after these patients, and that's what we need, really.
Absolutely. And so the existential problem that confronts us in healthcare is funding, isn't it? We are practicing really in an ethical minefield.
Yes.
If you're poor in Nigeria, you're far more likely to suffer adverse health outcomes because health follows a social gradient.
Yes.
So let's talk a bit more about funding and financing, therefore.
Yeah.
So how did you go about financing this project? I mean, Marcelle Ruth is an amazing place.
Thanks.
How did you go about it? I mean, if you had support, I'm assuming you've had support. You've alluded to some of it already. But how did you go about really doing the work of convincing local and international partners, financiers, that this was something worth investing in?
Okay, well, the answer to this is a very good question, and the answer from my point of view is quite simple, quite short. I'm going to have to be nice to my husband for the rest of my life, basically.
We have mentioned him several times in this conversation already.
Because he's my only investor to date. That's the truth of the matter. And so he believed in the story. Yes, we did, and he did try to raise funds, not just from local investors, but internationally. But I'm sure you're aware, having been back in Nigeria and being in the healthcare sector, that it's extremely difficult to raise funds. And it is, again, something that needs to change.
Sure.
And that, at the beginning, people want to see, they say that they want to see that it's going to happen and that, it's actually going to be profitable and it's going to, no one wants to take the risk. Whereas actually my understanding of backing businesses is to help them take the risk or take the risk with them.
Absolutely.
Especially in a world where we don't have these services and we have the need, right? So why are we this sort of, and what, again, even from the more international development banks, they all came to speak to us, or we spoke to them, or we found them. And even when we started the project, the hospital, they all came to see, because most of them, having had conversations with us 2-3 years before, couldn't believe that we'd actually done it. But they all want to lend in dollars in a market where we're going to charge the patients in naira, in a market where the naira can tank overnight, like it did not too long ago, and so on. So I think this is an important point, and I'm glad that you brought it up. I'm very extremely lucky because obviously my husband is a financier and has spent many years in private equity internationally. And when we got to the point where we were not actually getting this external funding, he just decided that, you know something, we're just going to do this. And that's what we've done. So massive sacrifice. But I think this is an important message or point to make, really, that healthcare sector in Nigeria, but maybe everybody says, well, it's Lagos at the moment, but I think also Abuja is happening and so on, needs funding. And the people who are trying to put these healthcare services in place, and there are quite a number of them, they need the support. Yes. They need the help. They need the belief. It's too hard, to be fair. It really is too tough. And we need every single hospital bed that we can have in Nigeria, in whatever part of healthcare services it is, because we just don't have enough. We're below the SDG goals in everything, right? And I think now the government, because I've listened to, and because I'm on this national task force for cancer control, which was really interesting. So with WHO and the IAEA, the Atomic Energy team that came last October, we did a visit to the health sector across Nigeria. And so for Lagos, with tertiary care, secondary, primary care, Abuja, Sokoto, Benin, you will be amazed. You will be amazed what is called a tertiary hospital in some parts of the country, and that's the access that patients have. So there is but I think it's clear that also the public sector can't do it quickly. In the private sector, we're a bit more nimble on our feet. The gap is the funding. Yeah. And so I think that private sector definitely has a big role to play, and that is being said time and again now. But if the funding and the funding opportunities and the backing opportunities need to be there, so that people can succeed, not just in setting up the services, but actually in being profitable and sustainable. Yeah. Because people come to a place like Marcelle Ruth, like they will to other hospitals, and think that why are you on about money, but actually we will close down if we can't pay our staff, and we can't pay our electricity bills, and we can't buy the drugs in, and so on and so forth. So it's a topic that's never really spoken to, because it's healthcare, as though it's not needed, but it's far from the truth.
Absolutely.
Funding needs to be there.
Absolutely.
For it to be done properly and to be sustained.
And of course, for people like you to continue to do this sort of excellent work, we must reckon with the reality that, of course, it has to be underpinned by sustainable business.
Absolutely.
So just so that we can continue to do all the wonderful things that you're doing. But let me press you a little bit further on a slightly more personal level. We talked about your husband a number of times in this conversation already. He's a great guy, wonderful guy. I spent a bit of time with.
Thank you. I've known him since.
I said, whenever you saying,
I still speak most of the time.
He's a very interesting guy, I have to say. But what has it meant to you personally? Considering the passion that is on display here today, and the need from within you to do this, what has it meant to you to have someone like that? And I dare say, not just because he's your husband, he comes from that world of financing. Yeah. To have someone like that believe in you and your vision.
Absolutely. I mean, you couldn't do it without. That's for sure. And that's why I'm saying what I'm saying for other people that I'm watching, even trying to do this. And in trying to providing the funding, or finding you the funding and the support, but also in the running of the business. Because I think one of the things that we begin to talk about now is there's the practice of medicine and there's the business
Quite.
of medical services delivery, right? And in Nigeria, a lot of our patients like to act as if we're all doing this pro bono, but and I think one of the successes there, if I may say so, although it's early days yet, of Marcelle Ruth is having somebody like Bolaji there, in terms of, if you look at the financial modeling that he did years before we even got in the door, which is actually underpins our day-to-day activity. Because as doctors, we know how to look after the patients. In fact, it gives us that's our gratitude every day. I looked after these patients and they're much better and so on. What we really don't know or understand is how to financially make the business run and to run it properly. And I'm the biggest person, I think about a year or so after we started, and I had all the patients who were owing the hospital money was because I had said, oh my gosh, it's a child and we have to start, and that kind of thing. And one day he called me in and said, something, do you want to run this hospital or do you want to run it down? You've got to make up your mind here about what it is. And he said, well, think about the fact that if you run it well and it is a profitable business, it will be sustained for years to come. And that's the legacy, that you will have a hospital that continues to run at excellent standards for the patients that you want to come. You have to think about it like that. Because if you're only thinking in the short term, you're not going to have the ability to keep sustaining it. And also, I think we need to mention all I don't know about this attitude, and I don't blame the patients, because I think there's been a big issue with sort of medical mistrust in the country. I'm not going to get the right diagnosis in Nigeria and so on. And you can't change people's attitude overnight, that's for sure. But I think it is important to say that there's now so many people who are practicing at a much higher level, and by grit and by hard work and by sacrifice, all of them. And it's not just me or you, there's quite a number. And some have gone back to not just Lagos, but the East. And there's the neurosurgery hospital in Imo State. There's the orthopedic in Enugu and so on, who were all trained abroad and who've all come back. There's, Professor Suleiman, also amazing stars who've come back. But when our patients, and because they're the ones who can go abroad, sort of feel that, well, even if they went to the US and they were given this bill, they'll pay it because, you don't question because you got the care. But when we're in Nigeria, why would I pay you? And one thing we all know is that the cost of care here remains significantly lower than if they went abroad, particularly if you're accessing care in the private sector abroad. I had somebody who came to me recently with immune thrombocytopenia. She was in hospital in the US for 5 days. Her bill was over $100,000. When we calculate, that is 200 million naira or something like that. I mean, we're not even, sometimes to say, but people have this thing like, oh, why are you expensive? Well, I mean, expensive is relative. I know that all my cancer patients, the ones who are coming back from abroad, 100%, one of the biggest reasons they're coming back now is because they can access this care here at a fraction of the cost that it would cost them abroad.
Correct.
And so we need those voices to say, look, it's a good thing to have good healthcare in our country where we can afford it better, and we are being looked after with our family surrounding us. We can go home to our beds at night. We're not in a foreign country. And so on. And for the investors, which is back to way, to take a risk on us and help us to build this better healthcare sector, which I believe as we grow will become, deliver better access to a wider socioeconomic group in the country.
Absolutely.
Yeah.
And there's a very incredibly important points that you make.
Yes.
Let me pivot a little bit to the question of what it actually takes to deliver that healthcare. And I want to talk about staffing and human resources.
Yes.
So you and I have a background
Yes.
in the National Health Service
Absolutely.
in the UK. And we know, of course, that 70%, for example, of the NHS budget is spent on staffing.
Yes.
Yes?
Yes.
But there is this trend, this phenomenon at the moment that is on the upsurge.
Yes.
Really, it's alarming the rate at which skilled healthcare professionals in this country, trained in this country, are moving abroad to the UK, to the US for the greener pastures. Really,
Yes.
can't blame them. But my question is, how do you cope with that?
Yes.
And how have you managed to retain the required level
Yes.
of skilled resource in order to deliver the excellent service that we know that you try to deliver?
Yeah, no, I mean, it's one of the, I mean, I think that if there's anything that makes us lose sleep every night, it's about the staffing, right? And, also, I know that, we can't blame them, but I do believe that we need to ensure that we try and stop this complete flood because, the amount of years that it takes to train doctors and even them with postgraduate, it's going to take this country and a lot of Africa, years to come back to where it needs to be to deliver good healthcare if we allow this to continue. I'm a real strong believer in that. And I do also believe that maybe having lived abroad for 30 years, but I know people look at you and say, well, you did it, right? It's not all roses and even particularly in the last few years in the US, let's not see what's going on recently with the political change. Even in the UK and in Europe, where the standard of living has become much more expensive without the support network that young people need during their careers and then trying to grow a family, compared to when we even went and we struggled, now it's a huge thing. So they're going, but actually a lot of them are not finding it easy.
Yeah.
That's for sure. Of course, they can't come back and say that that's the problem. And so I am a strong believer that we need to also look at a number of things. And one is how we pay our staff. And I'm going to come back to that in a minute. But also what we put in place to make sure our staff know that they're valued. And yes, because when you're training your staff now, everybody says, well, what's the point? They're going to leave. I don't think so. I think whilst they're with you, you don't have a choice. You've got to train. You've got to make sure that, and maybe when they see that they themselves are improving because they're there, they might see that actually I might not necessarily need to leave the country to go somewhere else because I'm getting this training here and I am getting better, and I will grow in my career because that's what people want to see, really. So from that point of view, I think we've done a number of things. We've created a number of roles that automatically show the people who go into those roles that there is a future for them as they grow in the organization, which I think has made a big difference, particularly in nursing. Because, you can't deliver good standards of medical care if you don't have good nurses. And I think that's one part of healthcare provision that I saw when I came back was how the nurses are not really valued and really given the opportunity to show how important their jobs are. So we've made a lot of noise about that on our ward rounds and so on. They're part and parcel of the primary team. It's not like the doctors go off and then go and tell the nurses what to do. They're part of the decision making. And at the beginning, they were so shocked. They never even used to say anything, but they had to. They asked the questions and they got to think quickly and clinically on their feet. And as they've grown, you can see the interest and the sort of sudden understanding and that this is where they will go. So that's the first thing. The other thing is training. And as you know, at Marcelle Ruth, we have been successful in getting accreditation to run an oncology residency program.
Congratulations, Mark.
Thank you. Thank you. I honestly, and I have to say that I'm very grateful to Dr. Alausa, the previous Minister of State for Health, because I was about to give up. That's one of those parts of your career when you say, well, something this is not worth my while. And he was like, no, we need to teach. You and I went to the best medical schools and so on and so forth. He said, look at who your parents were. He used the emotional blackmail. But also, I mean, I'm passionate about teaching,
Yes.
maybe not even as much as you have, because you've done a huge amount in medical education. But it's one of the things I wasn't expecting to even be thinking of doing this or doing this, but now gives me one of the greatest joy is the opportunity to really get involved with training the next generation in oncology, and maybe we'll do it in nursing, and maybe we'll do it in pharmacy. But you have to get through all these accreditations. But I think also we can't sort of think, well, they all live in the country, there's no point. I mean, you put all this effort. Yes, sometimes it is quite disheartening. You see your bright, shining stars who are really doing a great job, and then they see you on the corridor and they start smiling, and they're about to say, I just want to let you know, I just got my visa. Okay, all right, But something, some of them seem to be staying longer now than I would have expected them to do. So I do feel, and the other thing I will say is that, and this is not to say that we can afford to pay huge amounts or whatever, but I think sometimes when we think about hiring expat staff, the high salary, the house, the car, the everything automatically goes with the role, with the job. We don't think about it like that with our Nigerian staff. And I think, again, that needs to change. But that can only change if we get the institutional financial support.
Yeah.
So that we're not borrowing our bank rates, for example, and therefore we're not running a business where we're trying to pay down our interest.
Sure.
If that could be better, if we could really afford what we're doing, then we will be able to afford to pay people better. So, it'll come and roundabout. But I do believe that all of us who've had the opportunity to go abroad and who've made this step to come back or be involved in care here, I personally think that we have it's almost a responsibility to get involved in training. We did it when we were in the NHS. That's part of our jobs. It's part of your appraisal and your role. You had to. It wasn't a question about. So that's my attitude to it. We don't have choice. Got to train, and hopefully, maybe as time goes on, and I think as things are not as rosy, in some countries, people are beginning to realize that it's not that easy to go, and it's not that easy to sustain yourself when you get there. We will see a switch, I believe, and not everybody will stay, but I don't think everybody will be going in the droves that they are. That's my
Absolutely, and you've described a series of complex macroeconomic issues,
Yes.
really, that have a direct bearing on the problem we're discussing.
Yes.
Okay, so Dr. Elebute-Odunsi, I'd like, if you don't mind, to get a little bit personal
Yes.
now.
Yes.
I'd like to talk about your background and some of your inspirations growing up. That for me, I'm a bit of an outlier.
Yeah.
I was raised on legal fees. I come from a long line of lawyers, judges, and politicians. But you, Dr. Dupe Elebute-Odunsi, you're the second of 4 children born to parents, mum and dad, who were professors
Correct.
of physiology and surgery, respectively.
Yes.
That's a remarkable, amazing situation to be in.
Yes.
Must have been quite an inspiration.
Yes.
Can you tell me what that would have meant to you and how that influenced your decision to embark upon this journey?
Yes. So, I mean, absolutely, very true. You know, like I said, every time I walk into a room, the minute I mention the name Elebute, is gone before me. And, you know, uh, people know my parents very well, or they've been trained by my parents, or and were very involved and have a massive legacy in both the public education sector as well as in the private sector later on in their lives, starting not just the Lagoon hospitals, but probably the first and biggest HMO, the Higher HMO, as well. So I think it's the other way. But my father, again, was one of 4 children, and 3 of them actually did medicine. So when I got into medical school, there were 3 Professor Elebutes, because my aunt, my father's sister, was professor of radiology as well. But fortunately, my parents left soon after I got in to start Lagoon.
You had no
Lagoon
choice.
Hospitals. No, I didn't. But it's interesting because my parents were never, it was never about you had to do medicine. And like you said, 3 of my siblings are not medics, so but extremely successful in their careers in accounting. My sister is in the healthcare sector from a finance point of view, and my another sister is a successful lawyer and wealth manager. So I think for them it was all about just we did have the flexibility to be who we wanted to be. And I think particularly for the girls, my father always felt that he needed to let us know that we could be who we wanted to be. It wasn't about, you're not a boy or anything like that. And I think that's what we grew up with. But my earliest memories of wanting to do medicine stem back to when I was like 4. So I don't think I understood that my parents were really doctors or anything like that. And I have a very clear time in my mind when my father took me to go and see his mom, who was in Lagos University Teaching Hospital, and had her leg amputated from complications of diabetes. And it was more about, oh my gosh, when I grow up, I want to be the person who can make my grandmother be better, I think, was the first trigger. But later on, of course, the realization of being part of this very medical fraternity background, I think almost put me off at one stage, because how do you begin to think you want to go into a career where your parents have excelled? I mean, my father was not just a cardiothoracic surgeon, and there were not many of them in the country, but he was appointed a professor, I think, at age 36 or 37. So I think Professor Akikugbe in internal medicine was the youngest professor in internal medicine, appointed at 35, right? And my father, surgeon at 36. So that's what one grew up with. But I'm glad that for me, apart from the support that I had from my parents, that sort of just inner passion of wanting to do medicine was what I never wanted to be anything else. I've never ever wanted to be anything else. So when I talk to people who say they were not sure, then they were not sure. For me, I couldn't see myself being anything else. And I'm very grateful, it's the other way around, that I could be, because of course we went to medical school with people who didn't pass their exams, or later on when you went go abroad and had to pass BLAB or had to do postgraduate, the people who didn't get through. So actually being able to do the things that I wanted to do in medicine later on, for me, I think is a privilege, really.
Absolutely.
But yes, of course, you can't escape from your beginnings.
You can't.
I think that from that point of view, the inspiration there, or not just even the inspiration, they're like, you better not mess up kind of deal, was from knowing that my parents chose to pursue excellent standards of care. So my father was one of the people who started the Society of Quality Health, SQHN of Nigeria, for example, and brought to the whole thing about having international accreditation to show that actually you have gone that extra mile in terms of service delivery. So that's what I've grown up with. And maybe coming to Marcelle Ruth, knowing that I might as well not do this if I wasn't going to do it well and do it to those standards. I think maybe that's the impact, really.
Absolutely.
Yeah.
Dr. Elebute-Odunsi, it has been an absolute pleasure.
I've really enjoyed this. Thank you.
Talking to you on
Yes.
the One2one show. Thank you so very much. Most insightful.
Thank you.
Thank you.
Thank you very much.